Welcome everyone to the March iteration of IIDR combined rounds. It's my pleasure to host today. My name's Matthew Miller. For those of you who don't know me, I'm the director of the IIDR, and I'm subbing in today for Dr. Burrows, who is away for work, I believe, in UC Santa Barbara. So big weather upgrade for Dr. Burrows this week. Today, it's my pleasure to introduce our two speakers, Dr. Eva Piessens and Dr. Lindsay Kalan, who will be discussing challenges and opportunities in diagnosing wound infections. Dr. Piessens will be our first speaker, and Dr. Piessens is an associate professor in McMaster's Department of Medicine. She received her MD from Columbia University and her internal medicine and infectious diseases training at the Deaconess Hospital in Boston. She's a clinician educator in the Division of Infectious Diseases with clinical interests that include wound care, infections in the immunocompromised, and Lyme disease. And today she'll be discussing pathogenesis and the impact of infection on chronic wounds. Following Dr. Piessens, Dr. Kalan will present. Dr. Kalan's an associate professor in biochemistry and biomedical sciences at McMaster and a newly recruited member of the IIDR. So this will be a great opportunity for everyone to get to know a little bit more about Dr. Kalan's research program. Her laboratory is focused on factors shaping microbial community assembly in chronic non-healing wounds and interactions with the skin microbiome. And today she'll be discussing the microbiome as a biomarker in chronic wounds. I would ask those of you in the audience to please feel free to input any questions you have while the talk is going on into the Q&A window, which I'll monitor, and then I'll relay those questions to our speakers after both talks have been completed. So welcome, Dr. Piessens and Dr. Kalan. Thank you so much for agreeing to present today. And I will turn the floor over to Dr. Piessens to begin today's presentation.
Okay, thank you very much. Let me go ahead and share my screen. I'm going to talk about the clinical aspects and really going to concentrate on diabetic foot infections as a form of potentially a chronic wound, and the difficulty that we as clinicians have in sort of interpreting positive swabs, positive cultures within the clinical context. I have nothing to disclose. And this is a consult that I got within the last year or so, not an uncommon consult. And the referral was treat and follow osteomyelitis. So this is a 54-year-old man with reasonably well-controlled type 2 diabetes. And he presented to the office with about a 5-week history of a worsening left foot ulcer. It started after he went to his niece's wedding in a pair of new shoes. He had gone to a walk-in clinic over the weekend, and a superficial swab grew mixed bacteria, including Staph aureus and E. coli, and he'd been sort of self-medicating with some antibacterial ointment, wearing an old pair of sneakers that were loose. His sugars had gone up a little bit, but not remarkably. He saw his family doctor, who looked at the ulcer, looked at the culture, and again, referred him to me for osteomyelitis. So we will come back to this gentleman. Just want to point out that there's a huge number of people with diabetes. It's estimated that there are 422 or so, and this is an older estimate from 2012 in Canada. And of those, a quarter will develop an ulcer. Half of those will become clinically infected. And then about 15 to 20%, depending on where you look, of people who have a diabetic foot ulcer will actually undergo an amputation. So although the picture in the previous slide doesn't particularly look horrible, these diabetic feet ulcers can have serious morbidity and some mortality associated with them if not taken seriously. Diabetic foot ulcers are really neuropathic ulcers. So with hyperglycemia, nerve endings get affected. People may have minor trauma at points of pressure, often the tip of the toe or the metatarsal, sometimes the heel. Minor trauma, they don't feel anything. There's callus formation. The callus can sort of deepen and then crack and then bleed. And ultimately, you actually get an ulceration, which may become secondarily infected. And that's the typical pathogenesis. The typical process of wound healing occurs with any type of ulceration. And it's really 3 phases, although the first 2 are the acute phase. And so when you have a wound, whether it's a bite, a minor trauma, you step on a nail, it doesn't really matter. You have a period of active inflammation that lasts about 10 days, where you have initially lots of platelet activation, lots of complement activation, lots of polymorphonucleophils or granulocytes going to the site, and a lot of inflammation. Over time, so starting on day 1, averaging to about day 30, but peaking at about day 10, you start getting a decrease in that inflammation, in that acute inflammation. You get fibroblast deposition, you get angiogenesis, and eventually get re-epithelialization. And so you'll notice that the normal process of wound healing takes about 28 days, assuming there's nothing impeding that wound healing. The third phase of wound healing is what we call matrix remodeling. So that's remodeling of the scar tissue, increasing strength, decreasing vascularity from that acute onset. And that can take up to a year, depending on the insult. But that is essentially an intact epidermis and everything is happening underneath the surface. It's important to note that in diabetes, one of the things that can delay wound healing is actually the control of the diabetes itself. And so hyperglycemia has several effects on neutrophil function. So it'll decrease neutrophil arriving to the location, decreased rolling, decreased locomotion, and then increased adhesion where they are, as opposed to going to the site of injury. And then once there, they don't function as effectively. So there's decreased phagocytosis, and therefore decreased activity against microbes and increased potential for bacteria. And so people with diabetes, unlike a traumatic wound, unlike a venous stasis wound, do have that added factor that the diabetes itself is delaying wound healing. And that's a very important point to address with the patient. This is what I'm talking about, but more in a visual format. And again, this process happens in all types of wounds, including diabetes. In a chronic wound, you have sort of hyperproliferation of the epidermis around the wound. There's a depth to the wound. And at the bottom of the wound, you have this sort of gamish of bacterial colonization and biofilm formation that prevents angiogenesis, prevents any wound healing, and wounds have to heal from the bottom up, okay? Biofilm formation, and I know Lindsay is going to address this more directly, but biofilm is this sort of extramedullary or extra cellular matrix that bacteria sort of lie in. Different types of bacteria can communicate through them. They're in a somewhat protected environment in the sense that a biofilm prevents antibiotics from penetrating, and often will prevent local wound products from penetrating down into the bacteria, down into the epidermal layer as well. And so it's a nice cushy environment for bacteria to sort of stick to. So just to summarize, this would be considered a chronic wound. It has been more than 30 days. Now, I will say that there were several things that he was doing for himself that would have prevented the wound from healing normally. So again, glycemic control, it was good, but not perfect. He's putting on antibiotic ointment. Now, the hallmark of wound care is if it's wet, dry it. If it's dry, wet it. Antibacterial ointment sort of promotes a wet, non-healing environment, and people can often develop a reaction to that ointment as well, which can aggravate the inflammatory component of the wound. And then for him, his sort of old sneaker does nothing to offload that wound, right? So even before we talk about my specialty, which is infection, which is the osteomyelitis, there are several exogenous factors that are preventing this wound from healing that we are going to need to address, okay? The other main point is that all wounds have bacteria in them. And one of the difficult aspects as a clinician is to decide when and if to use antibiotics. One of the hallmarks of sort of bacterial colonization is that the longer the wound has been there and the more depth there is, the more polymicrobial your cultures will be. And so we all know we've got gram-positive cocci on intact skin. We have group A strep, we have Staph aureus in small amounts, other non-pathogenic bacteria. And with a wound, you still need to think about those. But the longer you have it, the more wet the wound is, the more likely you're to have gram-negative rods. And then with increasing depth and increasing local necrosis, so a local anaerobic environment, you start having anaerobes as well. And so all wounds are colonized. And there's this, you know, in clinical practice, this concept of a continuum from contamination, colonization, again, everybody's wound is going to be positive, to is it locally infected? Are these bacteria now actively dividing and causing an inflammatory response that is preventing normal healing? So local infection or critical colonization. This is, from a bacteria viewpoint, probably a tipping point for healing, non-healing. But as I'll show you, it's sometimes really hard to figure out where you are on a clinical viewpoint. Then you can have spreading infection. So this is where you're going to get erythema, you might get increasing pain, you might get fevers and chills, and obviously there's the potential for systemic infection as well. So where is my patient who does not have any significant external signs of infection on that continuum? Signs of infection can be quite subtle. So the classic signs of inflammation, erythema, induration, increasing pain, increasing warmth, drainage, are not usually visible or not usually occurring in that sort of tip-off between critical colonization and early infection. And so you're really trying to diagnose an infection before you have those classic signs of inflammation to give people antibiotics. Other things that sometimes are very useful is increasing pain. So the ulcer itself is not changing, but the pain underneath that ulcer is worsening. Increasing necrosis, increasing size, and particularly depth. And so you're starting to go down the layers of tissue. You might undermine the lip of the infection, which is that although there's still epidermis around that ulcer, the tissue underneath that epidermis is gone, and you can actually put your finger in underneath the skin. Delayed healing, again, may predict an underlying infection, but it's up to us as a clinician to figure it out. And so this is where, if you think there's an infection clinically, a swab might be helpful. So again, we don't do swabs to rule in or out an infection. All swabs will be positive when you have an ulcer. All swabs of intact skin are very likely to be positive. But if I think there's an infection, particularly if people have been on antibiotics before, a local swab may be useful in helping me determine which antibiotic I want to use. So somebody's colonized with MRSA, for example, and I wasn't thinking about MRSA necessarily, or they have a resistant gram-negative rod because they've been on ciprofloxacin several times. That may be useful in guiding the antibiotic choice. The other thing to think about before we go back to antibiotics is how deep does this infection go? And I apologize if anybody's eating breakfast, but for a diabetic foot ulcer, you always have to wonder, is there underlying osteomyelitis? So has the ulcer been there long enough for the bacteria to travel down into deeper tissue, into bone? And if you don't treat the bone, the overlying ulcer does not heal. So there's modalities to think about. There's the appearance of the ulcer. Obviously, if there's bone visible or palpable on probing. For a diabetic foot ulcer, that's actually about 85% specific for an underlying bone infection. Chronicity again, and sort of depth and duration are all things that we need to think about. If we're not sure, so in this particular patient, there was not a lot of signs and symptoms. There was not a lot of pain, except with pressure and walking on it. There was no rest pain. There was no probe to bone. So you have to decide whether or not your index of suspicion is high enough to do an imaging modality, such as a white blood cell scan. MRI, CT are all sort of appropriate modalities. And then there's the question of, okay, he came with a swab, or I've decided to do a swab. How useful is that for a deeper tissue infection? So it will tell you what is on the surface of the wound. Does it actually predict what's in the bone? And this is a study now, it's a retrospective chart review of people who were diagnosed with osteomyelitis and a diabetic foot ulcer by some imaging modality. And 76 of them actually had a bone biopsy done. 69 had a superficial swab done at the same time. There were more colony-form units, so more types of bacteria isolated from the swabs than from the bone. But look at the correlation. The bacteria from the swab correlated with the bone biopsy only 17% of the time. There was the greatest concordance with Staph aureus, and that would make sense. We know that Staph aureus is one of the primary causes of cellulitis and also one of the primary causes of osteomyelitis. So that concordance was up to 40%. But nevertheless, that swab for Staph aureus and for E. coli is not really helpful in terms of figuring out what antibiotics we want to do, either for a soft tissue infection or for an underlying osteomyelitis. This is just another visual representation from a different study. The pie chart on the bottom are the surface bacteria with Staph aureus accounting for 40% of bacteria isolated, but look at all of the other bacteria, including some gram-negatives, including strep, some Pseudomonas, and then some anaerobes as well. And then look at the deep tissue, the actual bone infection. And two things to point out. One is the lack of correlation, right? These pie charts look very different, just in colors. The specific organism is not so important. But look at the variety of pathogens. Can that be helpful in figuring out what antibiotic I should give if I'm worried about an underlying soft tissue infection or an underlying osteomyelitis in a patient with a diabetic foot ulcer? And so there's actually not a lot of trials, right? We're doing antibiotic therapy based on experience, I would say. There's really not a lot of trials comparing one agent to the other, and where there is, there's very little to suggest that one single antibiotic is the be-all and end-all of antibiotics and should be chosen over everything else. So the things that you want to think about in terms of the severity of infection. Is it a mild infection? So we're really looking at a cellulitis or subcutaneous abscess, but not something going into the dermis, not something going down to the bone. We know from studies of cellulitis that Staph aureus and beta hemolytic strep, such as group A strep, are probably the predominant organisms. And so something like a first generation cephalosporin or an anti-staph penicillin is probably appropriate. Now, notice for a mild or an acute infection, I'm ignoring the polybacteria data, and yet we have reasonably good chances of success for an infection at this level. If it's moderate, so it's a chronic ulcer, somebody has had a prior antibiotic and you're worried about a deeper tissue infection, such as a dermal infection or even a muscle infection, this is where, although you can't ignore your gram positives, you start worrying about gram negatives. And there are specific, exposures that should raise your index of suspicion for gram negatives, including things like Pseudomonas, which is a little bit more intrinsically resistant, and that's really moisture. So gram negatives love wet sneakers. If you're soaking your foot, even in tap water, if your foot is really moist and sweaty because it's summer and it's in an enclosed shoe, that's where we see more and more gram negatives. And so something like amoxicillin clavulanate, which is a fairly broad spectrum oral antibiotic that covers gram positives, gram negatives, actually has some anaerobic activity as well. If you're looking at a more severe infection, maybe ceftriaxone, which is a third generation cephalosporin and has more gram negative experience, although not Pseudomonas, and then metronidazole for the anaerobic component might be helpful. This is where, in the choice of antibiotic, the superficial swab might tailor your antibiotics. So if this had been a gentleman with a chronic wound and he's soaking his foot in Epsom salts, which people still do, and the superficial culture had grown not an E. coli but a Pseudomonas, I might have actually changed my antibiotic choice to cover that Pseudomonas, again, with the caveat that I don't know if that's what's going on in the deeper tissue, but he's at least been exposed to it. It may be in his bacterial milieu, and may be causative. Certainly, more severe infection with necrosis or ischemia, you absolutely need that anaerobic coverage. Remember that little graph, the more chronic the wound is, the deeper the wound is, the more polymicrobial, including anaerobic bacteria. And then certainly if somebody is severely ill, you're going to want to treat very broadly, including for resistant bacteria, until you get a sense of what's going on, both systemically and microbiologically. And so for this patient, there was no evidence to my exam of clinical infection of the skin or soft tissue. So there was no erythema, there was not significant swelling, there was no pain on palpation. So no antibiotics were given at that time. We did do wound care. So all of the things that I talked about, not using an antibiotic ointment, because we know that predisposes you to failure, using a proper antimicrobial dressing that has contact with the base of the wound. So you can use a silver dressing, you can use proviodine, but all of those are antimicrobial and will decrease the microbiome in that environment. Debridement. So he had a big callus that again would prevent any topical microbial to get to the base of the wound. And then finally, these non-antibiotic things. So offloading. If it's a pressure ulcer, you need to relieve the pressure. It's kind of common sense, or else the skin will not have a chance to heal. And then we talked to him about glycemic control and spoke to his family doctor about increasing his insulin just a little bit. Because of the chronicity, I did opt to do a bone scan, which was negative for osteomyelitis. So it's not 100% negative predictive value, but quite good. And then we saw him back with these conservative measures, and he had improved by about 50%. He came in at 5 weeks, so 50% in depth and in width, which is an appropriate sort of measure of improvement. Is even small wounds, if you remember the picture, it's fairly small looking, can take several weeks to several months to heal if you have taken away all of the factors that were preventing it to heal from the first place. And so even though the consult was for follow and treat osteomyelitis, it's not that simple, right? The wound swab in of itself is not diagnostic, even of infection. And so you have to really take a step back and think through on a patient by patient basis what this particular patient needs, whether it's truly antibiotics, whether it's wound care, what else can we do? That's not to say that, and I hope I've illustrated the difficulty in interpreting a wound swab within that clinical context, because all wounds have bacteria. That's I think what Lindsay is going to address. And what do those bacteria mean on a clinical basis? What do those bacteria mean from that patient is what I struggle with. The converse of just giving people antibiotics, positive swab, give antibiotics just in case, is obviously the development of resistance over time. So there's potential adverse effects. There's the potential for developing, for example, a ciprofloxacin-resistant Pseudomonas or developing MRSA. And the more resistant, the more chronic the infection, potentially the more difficult it is to treat. And so for me, one big sort of unanswered clinical question is, well, what do I do with these bacteria? They're there. We know they're there, but how meaningful are they in wound healing? And then do I really need to target my antibiotics with all of those bacteria? Remember that pie graph with the multitude of different bacteria isolated. Do you really need to treat all of those if you've decided there's a clinical infection in order to get resolution of the diabetic foot ulcer and then sort of prevention of all of the further complications? So that's it for my presentation, just to give you a sense of what the clinical world is with diabetic foot ulcers. And although it looks small, the potential morbidity and mortality if we get it wrong.
Thank you so much, Dr. Piessens. Very, very interesting and informative talk. I will pass the floor over to Dr. Kalan now, and I will relay questions for both speakers at the end of Dr. Kalan's presentation. So the floor is all yours.
Great. Well, thank you so much. I'm really excited to be here to talk about my research. Dr. Piessens gave such a perfect introduction to the work I'm about to talk about. I'm just going to jump right into some of the research that my lab's doing, really focused on trying to understand how microbes are assembling within wound tissue and if we can potentially use those as both targets for new therapies and potential markers for healing. So I think she's already gone through the scope of the problem. Impaired wound healing really is a major issue, particularly in the diabetic population, where 5-year mortality rates are very high, especially if some of these diabetic foot ulcers can result in an amputation, for example. And we know that many types of chronic wounds are polymicrobial. So questions my lab have really are focused on understanding how these microbes are assembling into the tissue. Typically in a chronic wound, we're finding skin commensals. Again, this was touched upon in the earlier talk, as well as things you might pick up in the environment, and then our traditional pathogens. And so the big question we have is, how are these microbes impairing or promoting wound healing before that, clinical infection sets in? So, at the time of colonization. We do most of our work in diabetic foot ulcers. I'm summarizing, a breadth of literature over about the past decade on this slide here. Traditionally, we might go to culture, you take the swab, you send it to the clinical microbiology lab. And I think as Dr. Piessens, really emphasized here, Culture doesn't necessarily predict if there's an infection. And we also know that it underrepresents the diversity of the microbes that are present within these wound tissues. And then there's also challenges with where do we sample, how do we sample, is that representing, the deep tissue, the bone, or the surface of the wound. Again, looking at diabetic foot ulcers, we find a lot of commensal bacteria, organisms like Corynebacteria, a lot of staphylococcal species, and then our obligate anaerobes. Work I've done as a postdoc that I'm not going to talk about today is also looking at fungal colonization. And we do find that if fungi are able to colonize some of these wounds, they're really associated with very poor outcomes such as amputation. And if we compare, sequence-based approaches versus traditional culture, we can detect, maybe 5% of wounds have positive fungal culture, but about 80% of swabs that we look at through sequencing, we do detect fungi within those samples. What the field does agree on, I think, is this concept of the infection continuum. If we think about this idea that once there's a break in the skin, you get contamination of microbes into that tissue, this really follows an increase in microbial bioburden that is, again, thought to follow the life cycle of a biofilm, right? Microbes are going to assemble, aggregate. As they expand, they're going to form sort of these three-dimensional communities, encapsulate themselves in an extracellular matrix. They're often polymicrobial. And again, this allows them to resist antimicrobials as well as host immune defenses, which tend to be impaired in a diabetic person. The evidence for biofilm in chronic wounds is largely based on microscopy, so collecting a biopsy of a wound and then actually looking for aggregates of bacteria, as well as DNA sequence-based methods. So we understand that it's polymicrobial from, culturing may give you 2 or 3 different organisms. Through sequencing, we know there's up to 15, 20 different species present within a single chronic wound. Work that we've done using shock and metagenomic sequencing, tracking things like antibiotic resistance has really told us that antibiotics do have a limited effect on the microbiome within wound tissue. So on the plot on the left here, I'm just showing you microbial diversity before, during the course of an antibiotic, and after in unhealed versus healed wounds. And what we find is that there's really no disruption or change in that overall diversity of microorganisms present. And then if we look at antibiotic resistance genes and predict the sort of resistome within these samples, on the right here is just a sample of 100 different patients that we followed over 26 weeks. Each of these little rectangles represents a visit, and the color of that rectangle represents the number of antibiotic resistance classes we detected. And what I'd like you to take home from this is there's a lot of red. In some cases, we're finding resistance to over 11 different classes of antibiotics. Again, supporting this idea that we really should be preserving antibiotic prescriptions in these patients for those that are experiencing maybe a more deep-seated infection or the osteomyelitis versus something superficial. So one of the challenges in diabetic foot ulcers particularly, and this has been identified by several regulatory bodies, is that clinical trials are really challenging for interventions because a lot of the assessment is subjective. Even with frontline treatments, they're only successful about 40% of the time. So it's really hard when a patient comes in to necessarily with high confidence predict if they're going to go on to heal or if they could potentially deteriorate and the wound could get worse. There haven't been very many drugs approved for chronic wounds or diabetic foot ulcers. And one of the areas that have really been identified as a call for action is the need for validated biomarkers. So can we go in, sample the wound, and look at a biomarker to detect whether or not that particular wound is going to respond to a certain treatment? So something we've identified as an opportunity in my lab is, can we potentially use the microbiome using these culture independent methods to identify high-risk patients right when they first come into the clinic so they can be triaged into specialty care and then predict what their wound healing trajectory is and their outcome. So work we've done and others have shown that the diabetic foot ulcer microbiome is really distinct and dynamic. What I'm showing you here is the timeline from 4 different patients. These are relative abundance plots. So each column is a visit that they came into the clinic, and each color represents the proportion of a bacterial species present in their wound at that time. And what I'd like everyone to notice is that not only do we see a lot of differences between individuals, so there's variation, it can change over time, right? So if someone's coming in for repeated wound care, they're maybe getting debrided to scrape away any devitalized tissue and biofilm. So you're going to have a disruption and then a reassembly of the microbiome. Topical antimicrobials may be applied, as well as the immune response may be changing. So there's a lot of variation between individuals, and then over time, again, we're seeing a lot of commensals like Corynebacteria species that are often ignored, but could be potentially playing a role in pathogenesis. And then again, as I think was really nicely pointed out, over 95% of diabetic foot ulcers that we sample, we detect Staphylococcus aureus in it, and that's showing you here in the brown. We've tried to dig deeper into this, so using shotgun metagenomic sequencing, where we can get into things like strain level variation and start to look at potential virulence genes. We have shown that there is strain variation within Staphylococcus aureus can drive outcomes. So for example, if we look at a set of patients and split them up by their healing time, where on the far left here are wounds that are healing within a 4 to 8 week period, and then on the right we have our non-healing wounds that are still persisting after 3 months, we do find strains of Staph aureus that appear to be associated with these persistent non-healing wounds. We can isolate those and put them into a mouse model. And again, those Staph aureus strains that are kind of found everywhere versus what we're calling a specialist strain and the persistent wounds, we do see in a mouse model of wound healing that the wounds are more inflamed, there's more biofilm, they're not healed after a certain amount of time. So this is really exciting. Can we potentially look at the different strains of Staph aureus to determine if antibiotics are warranted or not? But the challenge with this is just given the prevalence of Staph aureus within diabetic foot ulcers and the challenges associated with strain typing, this makes it a really challenging marker to target, to be able to collect the sample in the clinic and be able to get an answer quickly to inform your care. We've also done work where we have found that, again, the more necrotic tissue that's present in the wound, you see this increasing prevalence of anaerobic bacteria. Perhaps that's not surprising. We're also seeing a concurrent increase in pathogenic fungi. So along the x-axis is necrotic tissue of the wound, and then the mean proportion of these different types of organisms. We've gone on to look at anaerobic bacteria because they do seem to be associated with worse outcomes. And what we find is that if you debride really well, so again, debridement is scraping away the callus, dead, devitalized tissue, and potential biofilm. If we look at wounds that heal after a 12-week period, we do see this significant reduction in anaerobic abundance, which I'm showing you on the left here. Versus wounds that persist or end up in an amputation, the anaerobic bacterial populations remain the same. And then on the right is just looking at the overall diversity. So we do see a drop in that microbial diversity in healed wounds, and this is really driven by reducing the anaerobes. All of this work was done using either 16S or shotgun metagenomic techniques. Again, one of the challenges with this to use as a potential biomarker is that this does remain quite costly. It takes time. And using swabs, sending to the clinical lab, anaerobic species are just very challenging to culture. So one of the opportunities when I started my lab in 2018, was thinking about, can we potentially identify what really the most active bacteria are in diabetic foot ulcers? So we're using all of these DNA sequence-based techniques a question I continually get is, which ones are active? Are they alive or are they dead? And then can we potentially look at specific virulence factors as predictive biomarkers? And so can we turn that then into a simple bioassay that's just PCR based, a qPCR based bioassay that can be implemented into the clinical lab? So to approach this, we're using metatranscriptomics, where we're collecting samples from diabetic foot ulcers, doing total RNA-seq to look at both the host response as well as what bacteria are actively transcribing and which genes and pathways are upregulated, as well as our microbiome. So I just wanted to share some initial results from this study. This is my first time presenting it, so I'm open to feedback. We're quite excited about it. Just an overview of our study design. We enrolled 100 patients from a VA population in Wisconsin. They were followed for 12 weeks, and we collected anything that was debrided off the tissue, as well as a deep wound swab and then an intact swab from the contralateral foot, just to look at what's on the healthy skin. Did total RNA sequencing as well as traditional microbiome sequencing. This is just an overview of sort of the breakdown of the patient cohort, where we had a number of patients that ended up with an amputation, a number that healed over that time course, and then quite a few that their wounds were not healing or were ongoing. So one of the first things we needed to do for this is just look at the different sample types. We elected to collect all the debrided material because it's going to be very challenging to get high quality nucleic acid out of these samples. If we want to be able to implement into this clinic, we wanted to compare debrided tissue where we should get more tissue and more RNA, but not all care settings can debride. It's more of a specialized technique. So swabs are permissible across care settings. And also, if you're collecting all of that dead stuff off the surface of the wound, is that really representative of the wound base? You're going to have dead things, stuff from the environment, and devitalized tissue. So we really did a thorough comparison of these two sample types. So we were able to do our sequencing. We then got all of our RNA-seq back, and we just aligned all of our reads to human and bacterial databases. And so what we found was, if we looked at the amount of human reads present in the green here, comparing between the two sample types or those aligning to bacteria, we actually saw no differences between the two. So this was actually really promising to suggest we could use either if we want to be detecting bacterial transcripts. I think what was the most surprising to me, and that I'm very excited about, is when we look at the types of transcripts we're detecting from these samples. They're highly abundant in bacterial transcripts. So each of these points represents either archaea bacteria or eukaryotes, which would represent the host. And then the relative abundance of those transcripts is very linear between the two different sample types we had. And up here in the corner, it's really bacteria that were the highest. I think surprisingly, because I'm used to working with, metagenomics, where we're looking at DNA, what we found was that, in some cases, if we looked at the differences between human transcripts versus bacteria in the orange here, and then I have swabs all along the bottom and the tissue all along the top, some samples had over 90% bacterial transcripts. So that's suggesting that you have a really highly active, actively growing bacterial population within those samples. And when we look at what taxa are there, they're things that we would expect to see in diabetic foot ulcers. As a gut check, we compared our two sample types, and we find that they all cluster by person. So again, on the left here is just this network diagram is linking, our debrided tissue sample to the deep swab. And we're looking at how similar they are to each other. So all of our samples are clustering by patient. We have our intact skin is clustering away from them, which is what we would expect. And then on this PCA plot, overlapping again is just our gut check. We do find that tissue and swab samples overlap with each other. Those came from the wound. Our intact skin has a completely different signature compared to what is in the wound. So what's going on now? Can we potentially use this approach to identify taxa or markers in the microbiome that are more predictive of wound healing? So we started with doing this really straightforward comparison where we looked at the abundance of taxa or bacterial species present in our transcriptome versus using traditional 16S based DNA approaches. And so if they're perfectly correlated with each other, they should follow along this diagonal line. And what we found was anything above this line means that they're overrepresented by 16S or DNA-based approaches. And if we look at wounds that had healed within the 3-month period and those that remained unhealed, anything in yellow here appears to be overrepresented by 16S sequencing. And these are all our staphylococcal species. So these do tend to be overrepresented by 16S. And then we have a number of taxa that are falling below this line that are overrepresented in our RNA-based analysis, suggesting they're more transcriptionally active. So Alex Chong in my lab, a PhD student, came up with this activity index where he looked at the log of the RNA abundance to DNA abundance. And so in the graphs I'm about to show you, anything over 0, the 0 line, means that they're more transcriptionally active or metabolically active within our samples. And so we've colored these just for ease because there's, again, a lot of different species we're detecting in these samples. Here's our 0 line. Surprisingly, or perhaps not, is what we're finding in these persistent wounds. The pink, which represents all of our pooled anaerobic species, are really highly active in persistent wounds, and those that were unhealed at the end of the study or ended up in an amputation. So this really actually does fit with our previous studies using metagenomic sequencing to suggest anaerobes are really important. However, what's particularly exciting about this is what we're finding is that it's really in samples that have a very low abundance. So this is the 16S relative abundance, so the proportion of anaerobic bacteria based on 16S sequencing. And if we look here at the scale 10 to the -2, like these are samples that really, if you looked at it from a DNA sequencing perspective, molecular basis, you'd say the anaerobic population is very low. It's less than 1%. It's something we maybe don't need to worry about. But what we're seeing in these persistent wounds is that they're actually very active, suggesting that these wounds are potentially poised to have an expansion and a bloom of anaerobic bacteria that should be addressed. We've looked very closely at clinical parameters. So are these patients suffering from peripheral arterial disease, which again decreases oxygenation in the tissue? And we find no correlation with the overall anaerobe abundance in this disease state. And so in these plots, we look at the ankle brachial index and toe brachial index. Gray is the normal values. And if anything, we see more anaerobes in the sort of more perfused tissue. So this does suggest that we can use this as a potential biomarker. And so we're moving forward with this. Our goals are to develop a set of candidate prognostic markers where we will then take those specific taxa that we think are important or specific virulence factors they're expressing and design a multiplex qPCR based assay that could be implemented into a clinical workflow. And we're working with the Diabetic Foot Consortium to validate the strength of these biomarkers in a prospective cohort once we have our finalized list. And just to conclude, my lab is really interested in sort of going from bedside to bench, I guess, in an opposite direction. By working in these clinical cohorts with, the huge amount of variation, it really allows us to then understand what are the most important questions we should be following, and then we can do more mechanistic studies in the laboratory. And the last slide I wanted to end on, just because I'm new here and I'm really excited about potential collaborations and working with other people, is we do a lot of this work now using human skin. So we can get human skin from the clinic. We then can create biopsies in it. We can put them into culture, grow them, keep them alive, wound them, and then collect isolates from our diabetic foot ulcers and look at how they're actually assembling in the wound tissue. So this is an example of a wound colonized by Candida albicans. We do imaging to look at co-localization. How are these microbes actually forming? Are they forming biofilms? What do the biofilms look like at different depths within these wounds? And finally, how does that impact things like host immune response? And one of the major things we have found is that if we do look at these polymicrobial biofilms, we do see a dysregulated neutrophil response when they're exposed to them versus a single mono infection. And so just to conclude, we really do think the chronic wound microbiome is a promising biomarker. And for the basic research side of things, we're really excited about trying to understand if looking at these interactions in a model system will allow us to identify new therapeutic targets. And I will end there because we're close to time. Won't let me advance my slide, but I do really want to just thank, most of this work was done by Alex in my lab and my clinical collaborator, Megan Brennan. Thank you.
Fantastic. Thanks so much, Dr. Kalan. So there are a couple of questions from the audience. I'll start with a question for Dr. Piessens from Dr. Mertz. So Dr. Mertz writes, I only started managing osteomyelitis without universal bone biopsy plus debridement when I started to practice in Canada. Is there outcome data that shows our practice here has a similar success rate as universal bone biopsy and debridement is required before starting treatment of osteomyelitis?
So I would actually divide that into two different questions. I don't know if any, the response rate for diabetic foot ulcers sort of healing writ large is somewhere between 50 and 85%, which is a huge range, right? And Dominic, I've never seen an outcome study based on biopsy or lack of biopsy. And with the culture data that I have seen, I guess I would question what I would do with a bone biopsy unless for a chronic wound, right? I'm not talking about a bacteremic patient or a patient with an osteomyelitis in their vertebra, for example, where I think biopsy is actually really important. But for wounds, the theory is that it's really an infection from the outside going in, as opposed to a bacteremic infection that settles in one space. So I've not, to answer your question, I've not seen that biopsies improve outcomes. And with the data available, I'm not sure what I do with a bone biopsy in the setting of a chronic wound and how polymicrobial they are. That's a different question to me than debridement, because I think there's small studies that show that debridement is really useful in removing devitalized tissue so that wound care, for example, can get to the wound base. And so although I don't have a study for you, I would say anecdotal evidence would suggest that removal of necrotic tissue is useful in wound healing. But to me, the bone biopsy and then debridement are two separate issues, I guess. Sorry, that's a good, not long-winded non-answer.
That's great. Thank you very much. For Dr. Kalan, Dr. Coombs writes, do the staph that are associated with non-healing wounds have a different transcriptional profile compared to staph from non-complicated wounds?
That's a really good question. I don't know. We haven't done that experiment with those particular isolates. We did do a pretty extensive comparative genomics analysis, though, and we find that in the strains that were associated with the persistent wounds, we do see more in virulence factors associated with invasive infection and antimicrobial resistance, versus the strains that were sort of found everywhere had typical sets of like immune evasive genes, but not necessarily the toxins and other genes that are associated with an invasive infection.
Great. Thanks, Dr. Kalan. Another question for Dr. Piessens, or Piessens, I'm sorry. Is there evidence at all, either, I mean, sort of anecdotal or clinical trial based, to suggest that antibiotic treatment might negatively predict outcomes in people who don't have a bona fide infection in these diabetic foot ulcers? I asked this, I guess what I'm trying to get at is in dovetailing with Dr. Kalan's presentation, is there clinical evidence that maybe there are commensal microbiomes that tend to inhabit these wounds, just because they're in the vicinity, that might actually promote the healing process, as opposed to pathogens that are actually driving an inability to heal efficiently?
Yeah, that's a really interesting question. I don't have a study, and I've not seen in the literature a concept of normal flora for wounds, except that all wounds have bacteria, right?
Right.
And so, but I've not seen, if this bacteria is present, that's okay. If this bacteria is present, it's not okay. My sense is it has to do with numbers, burdens, and probably diversity of bacteria that then start delaying healing. In terms of antibiotics being harmful, I think where I've seen that anecdotally is the sequencing of antibiotics that target a superficial wound swab. So, you've got E. coli, let me give you, or you've got Pseudomonas, let me give you Cipro, without this understanding of what stage that wound is, and without understanding that you're really treating the tip of the iceberg. And if you're ignoring all these anaerobes, what you're going to do is promote resistance. For your Pseudomonas, you might promote MRSA, but you are not going to be healing that wound. Right? So I think it's really important to understand that diversity increases as chronicity and depth increase, and that you should always include anaerobic coverage for your more severe or deeper wounds, regardless of what that wound swab shows, right? So sequencing of antibiotics just based on the culture identified just promotes resistance and doesn't improve healing.
Great. So yeah, that I guess I'll just ask one sort of wrap-up question that dovetails from that last concept, and this could go equally, I think, to Dr. Piessens or Dr. Kalan, which is the data, Lindsay, that you showed regarding the detection of anaerobes being more prognostic of poor outcomes and chronicity. Is that a function of wound type? Like, does it tend to be that, it's deeper wounds that tend to have these anaerobes, and as a result of that, heal more poorly? And maybe also, I guess, that, if you're looking, as both you and Dr. Piessens mentioned, at swabs or even metagenomic data from these wounds, where there are polymicrobial communities, it's simply, well, not simply, but it tends to be the case that anaerobes are not, normally present, and therefore are just a much stronger overall predictor that it's a true infection, as opposed to, polymicrobial colonization of the wound that happens in normal circumstances.
So I can comment that we have looked very closely at the host factors and microenvironment. So we find no correlation with things like tissue perfusion and the level of anaerobes. So you might expect that as the tissue is less perfused, you're going to have more anaerobes, or wound depth or wound size, from the sequencing perspective. So that's why we do think this will be a really good biomarker. I suspect it's actually a function of the localized biofilm, for example. So of course, if there's a biofilm forming, you're going to have different levels of oxygenation just within that aggregate of particular microbes. Of course, I think if you have and again, I'm not a clinician, so Dr. Piessens can speak to this. I think if you have a suspected anaerobic infection, that can be quite obvious, like there's odor and other signs.
Right.
You know, we're excited about this because we think this is a really early biomarker. So before, you know, they sort of take over and you have a more of a spreading infection.
Thanks, Dr. Kalan. Anything you'd like to add, Dr. Piessens?
No, I think Dr. Kalan's data sort of reemphasizes for me that I need to think about anaerobic coverage maybe even earlier than I think, because by the time you have odor, by the time you have necrosis, it's kind of too late, right? I think what would be really interesting is to take those early wounds, at least sort of chronologically early wounds, and give them sort of standard of care or standard of care plus anaerobic coverage and see if you have an impact on wound healing. Because right now that would not be the standard of care, right? The standard of care would be just to treat those gram positives. Do you have an impact on wound healing if you use anaerobic coverage up front for diabetic foot ulcers? That actually is a very interesting question.
Great. Well, on that note, my sincere thanks to both of today's speakers. I thought this was an incredibly fascinating session and a match made in heaven from the clinical and research perspective on this topic. So thank you so much. And of course, thank you to everyone in the audience who attended today. We will see you all again in a month, I hope.